In the name of Allah, the most beneficent, the most merciful. Assalamu alaikum. I am Engineer Asadur Rahman, Research Scholar, Department of Electrical Engineering, UET Texla, Crew Chief Control System Engineering and Finance Manager, Community of Research and Development, CRD. We have a collaboration with Artificial Research and Development, which is affiliated with Track of Computer Engineering Department, UET Texla. Today the topic I am going to present is automated system design for classification of chronic lung viruses using non-linear dynamic system features and K nearest neighbor. I am presenting my paper in Muhammad Ali Jinnah University Conference on Informatics and Computing 2021. My co-authors are Engineer Misha Aruj Khan, Engineer Aisha Farman, Engineer Nida Israr, Engineer Muhammad Zulkarnain Haider Ali, Engineer Zulfikar Ali Gulshan. Contents, progress steps, motivation, introduction, literature review, materials and methods, experimental results, conclusion, references. Motivation. Chronic lung virus is a very common lung disease that needs an accurate diagnosis at the outset to receive adequate care. 1 billion people suffer worldwide, 3 million people die each year. Many techniques have been made for the diagnosis of lung diseases using cough symptoms, breath sounds and image recognition over the last few years, but they are quite expensive and their results come from quite some time. We present a comprehensive and groundbreaking technique for separating untreated lung viruses from healthy subjects by using breath sound analysis in this paper. The technique used are thermospectrometry, flu RF, SOM, fluid dynamic model, IoT based pulse oximetry kit. Introduction. Viruses worldwide. Humans have been fighting against viruses since the dawn of time. Several viruses have spread in recent decades, caused large scale outbreaks and killing thousands of people. These viruses are like Ebola, Pneumonia, smallpox, HIV, swine flu, coronavirus, Nipah in 1998, Hendra 1994, bird flu 1997, Ebola 1976, bird flu 2013, MERS 2012, SARS 2002 and COVID-19 in 2019 to this time. Flu virus. Flu virus is a viral infection that infects the throat and on occasion the lungs. It can range in magnitude from moderate to deadly. The influenza virus is not the same as a common virus. Flu patient shows symptoms such as fatigue, frantic visual vision, vomiting, extreme coughing, sneezing, muscular or bone joint pain and migraine. Some people may develop nausea, diarrhea and dehydration. Rhinovirus. Rhinovirus were first recognized from people experiencing common cold symptoms over 60 years ago. The common cold is caused primarily by the rhinovirus. Rhino infection spreads in the nose at the temperature of 33 to 35 degrees centigrade. Rhinovirus can lead to grave implications in receiver of lung and stem cell transplantations such as obliterative bronchitis and acquired graft refraction. Comparison between flu virus and rhinovirus. Here we have the parameters for the flu virus and rhinovirus. The first parameter is sign and symptom. In flu virus we have the flu. In the rhinovirus we have cold. Symptoms onset. For flu virus we have abrupt. For rhinovirus we have gradual fever. For flu virus we have usual, for rhinovirus we have rare. H's. For flu virus we have usual, for rhinovirus we have slight. Chills. For flu virus we have fairly common, for rhinovirus we have uncommon. Fatigue or weakness. For flu virus we have usual, for rhinovirus it is sometime. Sneezing. For flu virus it is sometime, for rhinovirus it is common. Chest discomfort or cough. For flu virus it is common, for rhinovirus it is mild to moderate. Stuffy noise. For flu virus it is sometime, for rhinovirus it is common. Sore throat for flu virus, it is sometime. For rhinovirus, it is common. Breath sound analysis. Breath sound analysis involves recording the patient's lung sounds via an electronic device, which is followed by computer analysis and classification of breath sounds based on specific signal characteristics. Auscultation typically take place in clinic setting where there could be multiple sources of ambient. This approach allows physicians to evaluate an abnormal breath sound precisely. Literature review. From the literature review, first we have thermal spectrometry in 2004, a very effective biomolecular testing tool. The attachment of flu virus to HA can be monitored using graphene-coated IR screens. FluRF in 1989, a tool using reconstructed polygenic trees for the identification of influenza virus reassortment. This technique used bottom-up research of the candidate segment-based polygenic trees and flu genome. SOM technique, which is also called as self-organizing mapping technique. In 2012, seasonal flu in mainland China in 2006 is analyzed using an advanced or improved SOM technique based on neural network clustering algorithm. It is efficient and ideal method for data mining to reveal the regulation of disease. IoT-based pulse oximetry kit 2020. The main focus is development of portable pulse oximetry kit products with GPS and their integration with mass products. IoT technology created a deep learning based model to classify and locate pneumonia using X-ray images. Chest radiograph classification system 2020. The investigators suggested a deep learning algorithm to distinguish between pathological and normal cases from COVID-19 using the algorithm is accurate detect with 93.94% accuracy. Material and methods. Proposed methodology. The first methodology is architecture. The second methodology is database collection. The third methodology is noise reduction technique. The fourth one is Swiss-Key-Galois filter. The fifth one is NLD's features, and the last one is classification. Architecture. In the architecture, the proposed method for the detection of flu virus and rhinovirus subjects, a digital surgical mask fitted with a microphone records the breath sound. The recorded raw breath sound is pre-processed through an interval-dependent based noise reduction technique which successfully removes high-frequency artifacts. The pre-processed signal is filtered by using the Swiss-Key-Galois filter technique. After that, 5 nonlinear dynamic system domain features such as SE, LE, CD, AE, and SE are derived and merged to create a concise and accurate feature depiction of normal and abnormal breath sound. These attributes are then used to train the medium K nearest neighbor classifier with an accuracy of 99.4%. Architecture is also shown here. It is where the person having a surgical mask with mini microphone, artificial amplifier on stage, analog to digital converter, breath sound acquisition. Then we have processing and segmentation where we have Swiss-Key-Galois filter, interval dependent denoising technique which is connected to feature extraction and selection, that is also called digital signal processing, that is connected to machine learning system which is classification of medical diagnosis decision. Then we have normal breath sound, flu virus breath sound, rhino breath sound, and from that medical expert can see the results of normal person or flu virus or rhinovirus person. Database collection. A low cost and efficient breath sound sensor is designed to gather sound dataset for the detection of chronic lung viruses. The system includes a surgical mask, a sensitive microphone and amplifier circuit, and a sound card. By placing BS near the left-right nostril, the microphone starts sensing breath sound. During the complication of BS, each participant produced 30-second signal in the virus plate. Normal breath sound were collected from the stable lung donors and abnormal breath sound from hospitalized patients with flu virus and rhinovirus. The survey patients include both men and women of various ages. The frequency range of breath sound signal is from 0.1 to 2 kHz, and the sampling frequency of the experimental signal is said to be 4 kHz by using Nyquist sampling theorem. Here we can see that the female subjects are for the normal person is 20 and samples collected from them is 200. The male subjects are 26 and the sample collected from them is 260. So it becomes the total 460 readings from for a normal person. For a flu virus, we have 32 female subjects. The reading collected from them is 304. Then we have male subjects 20 and sample collected from them is 200. So the total samples collected from them is 504. In rhinovirus, the female subjects are 25. The samples collected from them is 250. The male subjects are 24. The samples collected from them 240, and on a total it becomes 490. Here we have the breathe sound before denoising and filtration in the form of amplitude and time. Then we have flu virus breathe sound before denoising and filtration in the form of amplitude and time. Then we also have the reading for the rhinovirus breathe sound before denoising and filtration in the form of amplitude and time. Noise reduction technique: observable distortion, spontaneous electron movement in digital recording equipment due to thermal turbulence produces a dominant noise type. This excited electron rapidly introduce and eliminate the voltage of the output signal. Then we have NRT. Here is where a noise reduction technique NRT come at hand. Then IDD. So in order to make our BS signal noise free, we applied interval dependent denoising technique. Then we have orthogonal wavelet. To reach a certain limit, minimum, maximum threshold and soft threshold are used to change the wavelet coefficient. We also have the formula for orthogonal wavelet. Filtered breathe sound. Filtered breathe sound can be obtained as the inner product of raw breathe sound and spanning set. We also have the filtered breathe sound formula. And we also have the reading for the denoise normal breathe sound, denoise flu virus breathe sound, and denoise rhinovirus breathe sound in the form of amplitude and time. So Swiss-key Gloy filter, the data precision can be improved by smoothing the digital data points. A Swiss-key Gloy filter is a digital filter used for the purpose of smoothing the data based on concept of convolution. This process uses a linear least square method in which successive subsets of adjacent data points having low degree polynomial are to be fitted. We also have the formula for smooth breathe sound, raw breathe sound, and H estimated factor, and also have the readings for the denoise normal breathe sound, denoise flu virus breathe sound, and denoise rhinovirus breathe sound in the form of amplitude and time. Then we have the nonlinear dynamic system. NLD feature. A nonlinear system is one in which the output change is not proportional to the input change. Nonlinear dynamic system explains fluctuation in time variable that appears chaotic, unpredictable, or paradoxical as compared to simpler linear processes. We also have the scatter plot of nonlinear dynamic system features in the form of Lyapunov exponent. For a uniformly sampled time domain signal, Lyapunov exponent can be obtained using the sampling frequency. We also have the formula for Lyapunov exponent. Shannon entropy. Shannon entropy is a calculation of information for a random variable. It is also called the information entropy or entropy. We also have the formula for Shannon entropy. Correlation dimension. It gives an estimated slope of the correlation integral. The CR versus the radius of similarity. Raw signal range. We also have the formula for correlation dimension. Approximate entropy. It quantifies the amount of regularity and fluctuation uncertainty for time series data. We also have the formula for approximate entropy here. Spectral entropy. Spectral entropy is a Shannon entropy based signal measurement of the spectral power distribution. We also have the formula for it, and we have the data prediction for Lyapunov exponent, Shannon entropy, correlation dimension, approximate entropy, and the last one spectral entropy. So from these graphs we have the better knowledge of our topic. Classification gives a solid base. Classification gives a solid base for the data analysis to extract important features from the models. It is necessary to categorize the given data set into different classes, often termed as target, label, or categories. It involves a predictive modeling task that approximate the mapping function from input variable to discrete output variable. Here we have mid k nearest neighbor to train the extracted NLD's feature set. We also have the formula for normal breathe neighbors, flu virus breathe neighbors, and rhinovirus breathe neighbors here with us. So experimental results. For experimental result, first we have the performance evaluation parameter. We use several performance matrices derived from the testing dataset by measuring sensitivity, specificity, false value, true value, accuracy, precision. For true value, accurately observed breath sound. Then we have quantity that does not contain disease, yes. Fn, quantity that does not contain disease, no. Fp, no, number of incorrectly predicted breath sound. MKNN classifier. We also have the formula of formula for the sensitivity, specificity. We also have the formula of true value, accuracy, and precision here with us. So we have the classifier performance. Medium KNN classifier took 26.928 seconds to train the nonlinear dynamic system feature with a predictive rate of 25,000 observations per second. The total misclassification cost of the prediction value is 10. Medium KNN used 10 nearest neighbor per prediction value. This classifier scored 99.99%, sensitivity 97.82%, specificity 99.4%, accuracy and precision is 99%. The false value for NBS is 2%, while true value for NBS is 100%. So we have RVBS is 98%, and FVBS is 100%. RVBS is said to be right value of breath sound, and FVBS is said to be false value of breath sound. Feature analysis. The participation of all classification feature is not identical. We check the significance of each feature and test the competent classification model by using different feature subsets. We use the medium KNN because it outperformed the other classifier. This research used the real-time collected dataset to evaluate the performance of 3 nonlinear dynamic system feature. For this research methodology, CD medium KNN combination gave an cumulative accuracy of 99.4% with a misclassification cost of 9%, training time of 1.154 second, and prediction rate of 31,000 observation per second. So here we also have the combination for medium KNN in the form of LE, SNE, CD, AE and SE, and for them we have the cumulative accuracy, training time, predictive rate, and misclassification cost with us. So the evaluation of true positive and false negative rate, we have the true positive and false negative rate in the graphical form as well as in the tabular form. We have seen the classification of medium KNN with LE, SNE, CD, AE and SE, and their true positive rate and false negative rate is also discussed in the previous slide. So the table and figure show the true positive value and false negative rate of different feature combination with medium KNN. Comparative analysis. Table shows the comparative analysis of our proposed methodology with existing technique in literature. In the first study, we have the domain extension transfer learning, which is classified in COVID-19 pneumonia normal, and accuracy is 19.13%. In the second study, we have the technique on conventional neural network, and it is classified in normal pneumonia and accuracy is 99.2%. In the third study, we have sport vector machine, which is classified in asthma pneumonia and accuracy is 96%. And fourth study is assemble bag tree, and it is classified in normal bronchial asthma and accuracy is 97.4%. And our proposed methodology is interdependent disnoying Swirsky Gloy filter, which is classified in normal flu virus, rhinovirus, and accuracy is 99.4%, which is the accuracy of our proposed system or our design system. So in the conclusion, we have the several points. The first point is we present a comparative we present a comprehensive and ground-breaking technique for separating untreating lung virus from healthy subject by using a brief sound analysis. The second point is that the Swiss-key Glow filter was used to filter the raw brief sound signal after it was pre-processed with interval-dependent denoising. The third point is a detailed investigation was used to assess the most important feature combination for healthy and disease type signal. And the fourth and the last point of the conclusion is said to be finally using a five-fold cross validation method. The best properties of dimension is 1 cross 5 were used to train and evaluate medium KNN yielding an accuracy of 99.4%, specificity of 97.82%, and sensitivity of 99.99% with error less than 0.01. References. The mainly references are here. The first one is 1989 paper, the second one is 2005 paper, the third one is 2004 paper, the fourth one is 2012 paper, the fifth one is 2020 paper, and the last and the recent one is from one of our writers is in 2021. Here are the main references for understanding of our paper. Any question? That's it from my side. Thank you for listening and participating in my presentation.
Bismillahirrahmanirrahim. I, Engineer Ali Raza. I am a research assistant in Swarm Robotics Lab, UD Texla. I am also a joint secretary in Community Research Development. I am here to present research paper presentation which is deep learning based intelligent classification of COVID-19 and pneumonia by using cough oscillation collected by a oscillation sensor. The author of this paper was Ali Raza, Zubair Saeed, Sayyid Zuhaib Hassan Naqvi, Sayyida Zahra Ali, Misharuj Khan, and Zishan Abbasi. These are the contents which I covered throughout the presentation. First of all, I discussed motivation, then introduction, then diagnosis, then literature view, material and methods, results, discussion, conclusion, at the end references. First of all, we discuss the motivation behind COVID-19 to do research in this domain. The World Health Organization has designated COVID-19 a pandemic because its emergency has influenced more than 50 million world population. Around 40 million deaths have been reported worldwide from COVID-19. In this research work, we have presented a method for autonomous screening of COVID-19 and pneumonia subject from a cough oscillation analysis. Deep learning based model MobileNet V2 is used and for a self-collected data set. So these are the motivation behind do research work in this domain. Affected because of COVID-19, 50 million people are affected globally, and more people are elderly. So we have choose a domain to do a research in this area. This is the motivation also to do work behind in this domain. So what is the COVID-19 and what is coronavirus? What is its symptoms? We have discussed first of all here. So COVID-19 began on December 31. It is a family of virus affecting respiratory tract, causing disease from common cold to pneumonia, usually live in bats and other animals, transmitted human directly or via other animals. Can transmit human via respiratory droplets. So what is the journey of the COVID-19? And it starts from China and spread throughout the world. This is a journey of the COVID-19. COVID-19 began on December 31, 2019 with a report of unexplainable reason of pneumonia in Wuhan, Hubei province, China. It spread around the globe and was declared as a pandemic all over the world. Pneumonia caused by the influenza virus and other type of occurred throughout the season. Differentiate COVID-19 from a general pneumonia might be difficult in some cases, especially when clinical characteristics are considered. Fever, tiredness, dry cough. These are the symptoms of the COVID-19. This is the journey and it's spread all around the world and globe. So what is the symptoms behind the COVID-19? These are the symptoms of the COVID: shortness of breath, high fever, vomiting, pneumonia, coughing, and diarrhea. These are the symptoms of the COVID-19. So what are the diagnoses for the COVID-19? There are the two techniques for diagnosis. First one is the reverse transcription polymer chain reaction testing. This kit is not easily available in some regions due to lack of adequate supplies, medical professionals and healthcare facilities. The other one is the artificial intelligence technique. Artificial intelligence has been spreaded all around the world and it is the best way to do everything. So we have used artificial intelligence for classification of COVID cough and pneumonia cough. Recently, artificial has implemented in the health sector. Widely, there are also many applications in the field of speech and audio. AI has created its space. It's used for screening and early detection of different diseases. In our case, we have a classification of COVID and pneumonia. So what is the literature view for do research work in this domain? So we have read different papers. These are the similar one which I have mentioned here. So first paper is used for classification of COVID-19 using X-ray images. The method which is used for ResNet 50 and the accuracy achieved in this method 96.7%. And the other one, second one is use also a ResNet, but the accuracy also 96.23, but it's use a transfer learning technique. In this technique, it's use images to classify COVID and pneumonia. So fourth one is the also a classification technique, and it's also a transfer learning with multiple classifier. It's used spot vector machine, gradient boosting trees, and logistic regression were tested. The highest accuracy was 80% in this case. And the fifth one have also a classification technique, but this is also COVID cough signals. These signals also classify using machine learning approach into COVID positive and COVID negative signals. These are the literature view. So now we have discussed about the materials and methods. So first of all, we have discussed what is the method which I choose to do a classification of COVID cough and pneumonia cough. So we have a WildNet version 2 and we have a transfer learning technique to do classification. We have a self-collected data set. The data set is used in dataset in the audio form. Then we have convert the audio into spectrogram first. Then we have normalize. In normalization, we have resize the image. First we have a 400 into 400 size image. Then we have normalized into 224 into 224. Then we have passed the data set into a MobileNet version. Then we have a classification. Then we have a output layer. Then we have a prediction of COVID cough and pneumonia cough. This is the method to do classification in our case. So what is cough osculation and what is the dataset we have discussed here? A dataset osculation and distribution, we have acquired a self-collected dataset. The data include a stethoscope, sensitive microphone, sound card and a laptop. These are the steps which we have used to do collected a dataset. So the stethoscope, microphone, sound card and laptop. So first of all, in laptop we have saved the audio file, then we have convert into spectrogram, then we have passed over dataset into a MobileNet version 2, then we have a prediction of COVID-19 and pneumonia cough and COVID cough. This is the dataset. First of all, we have a audio form, then we have a audio convert into spectrograms, and the spectrograms also have male samples and female samples. These are the description of the dataset. So these are the dataset. First we have a cough osculation of COVID-19 subjects in the audio form, and then we have convert into spectrograms, and the spectrogram also show here. So first of all, we have pre-processing. Following are the steps in the input selected deep learning model. So we have a raw cough dataset is converting into a respective spectrogram. The deep learning has strong capacity to perform a better input images data, while we convert each cough sample into a spectrogram wherein the X contains the time of the sample and Y in the amplitude of the frequencies against each time. Each cough sample is captured with a window size of 0.25 millisecond, then converted into a spectrogram in resize and normalization. Each spectrogram has a size of 400 into 400. During conversion, it was resized into 224 into 224, which is required dimension of MobileNet 2 as shown in the fig. After normalization, we have a deep learning model MobileNet version 2. MobileNet version 2 is also used for classification. It is the best technique to do classification. So we have used MobileNet version 2. Then we have a transfer learning in the fully connected layer also for classification. We have used different learning rates to do for this method 0.05, 0.005 and also a 0.05. Classification and prediction. Classification of pneumonia cough and COVID cough is performed using deep learning approach by modifying the softmax layer, which is based on average pooling. The softmax layer is changed into two output, which is COVID cough and also a pneumonia cough. MobileNet version 2 is trained using transfer learning approach. It was initially trained and validated for ImageNet dataset, but it trained on the self-collected dataset of generate new weights. So now we have discussed the results. We have used different learning rates for so best learning rate. We have achieved 99.98 accuracy, 0.05 we have a 95.83, 0.05 we have a 99.45%, and at 0.005 we have a 99.98% accuracy. These are the results which we have achieved in our case. These are the training accuracy graph show. We have here epochs, training loss, training accuracy, validation loss, validation accuracy. This table demonstrate the training and validation accuracy along the respective laws and against each epoch. So this is the training and validation accuracy graph. This shows the training loss, validation loss, training accuracy, and also our training validation accuracy. These are the parameters which we have evaluate our our model accuracy, precision, recall, F1 score. These are the parameters we have used to evaluate the MobileNet version 2. After the model training, we have a random prediction of images. We have experiment randomly and input each class sample to the proposed system. Its result into right class label against each sample is shown in the figure. Pneumonia spectrogram is predicted with a confidence of 98.87 and COVID cough is predicted in to 99.04% confidence. And the next one is conclusion. COVID-19 is a dangerous disease that emerged December 2019. Some of the symptoms overlap with pneumonia. Digital Auscultation and COVID analysis can provide a non-invasive method to identify abnormalities in this research work. Deep learning method is applied to cough sound of COVID and pneumonia subject. The presented research work has provided sufficient evidence about the satisfactory performance of the proposed methodology. Moreover, the proposed system has achieved 99.98 accuracy. And extended version of this article, we have aiming to explore deep learning model on cough analysis, comprehensive analysis. We also aiming to implement deep learning model in the NVIDIA Jetson Nano and also for provide the solution AI on the edge. These are the references, and thank you. If you have any question, please ask me.
In the name of Allah, the most merciful and beneficent. I, Zubair Said, Research Assistant in a Swarm Robotics Lab, National Center of Robotic NCRA, and also I am a General Secretary of the Community of Research and Development CRD. I am here to present my paper presentation, that is classification of a pulmonary viruses X-ray and a detection of a COVID-19 based on invariant of Inception version 3 deep learning model. Among other authors are Misha Roj Khan, Ali Raza, Harim Khan, Javeria Javed, and Aksa Arshad. Contents. Throughout my presentation, I will be following introduction, objectives and motivations, proposed methodology, results and discussion, and in the last, I will be presenting conclusion and a future direction. Introduction. The coronavirus, pneumonia and influenza disease have almost similar symptoms, where the COVID-19 has symptoms like fever or a chills, dry cough, sore throat, shortness of a breath, headache, loss of smell and a taste, muscle aches, whereas in pneumonia we may suffer in a trouble breathing, fever, pain in the chest, cough. We may have suffer these symptoms influenza, and these symptoms are fever, itching muscles, sweat, dry persistent cough, and a breathing problem. Motivations. Coronavirus is a fatal disease that have already infected several million individuals and caused thousands of deaths globally. Any technical technique that enable quick testing of a COVID-19 with a high accuracy might be essential for the healthcare provider. X-ray images is an essential available technique that might be a great option for its quick detection. Proposed methodology. In our proposed methodology, we have a dataset acquisition, system requirement, pre-processing, dataset augmentation, and model compilation. Dataset acquisition. We have acquired the dataset from publicly available repository named Kaggle. The dataset was gathered by the researcher from a Qatar university, the University of Dhaka, Bangladesh, where the Pakistan and Malaysia collaboratively collected the dataset and published it online. This dataset has X-ray images from the patient infected with the coronavirus, pneumonia, and other healthy people. Here is a table showing the class type along with the total X-ray images against each class. We have total 21,165 X-ray images. There in a COVID we have 3,660 images. For the normal we have 10,192 images, while for the lung opacity we have 6,012 images. However, for the viral pneumonia we have 1,345 images. Pre-processing. We have resized the dataset in a fixed size of 299 cross 299 dimensions according to the required size of the Inception V3 deep learning model. Dataset augmentation. We have increased the size of the original datasets into 3 times by flipping, rotating, and scaling respective images. We have total chest X-ray images of 27,165 belonging to the original datasets, whereas they become 81,495 after augmenting, which is 3 times the original datasets of X-ray images. Fig shows the total number of the chest X-ray images with and without augmentation, a total of 27,165 images belonging to the original sets, whereas they become 81,495 after augmenting, which is the 3 times the original datasets. Here in the green there is original datasets, while in the blue there is augmented dataset against each class. Classification. Figure has been shown the classification results of a pneumonia class along with the achieved confidence during prediction using augmentation and without augmentation. Table has been shown the training and validation accuracy and a loss against each epoch. We have trained and validated the original and augmented dataset for a total 10 epoch and found these values during training process. Results. We have trained and then validated our Inception version 3 deep learning system using with and without augmentation approach. Here it has been shown that we have achieved the higher accuracy by keeping the learning rate of 0.0001 without augmented the dataset. Other learning rate of 0.01 and 0.001 using with augmentation, without augmentation, and the achieved accuracy can be shown from the respective table. Here we have the graph showing the training and validation accuracy and a loss of the system using with and without augmented dataset approach against total 10 epochs. Conclusion. It is concluded that the COVID-19 virus have dangerous effects on the health of the people. We choose Inception version 3 deep learning model and added 2 dense layer which ultimately increased the overall accuracy of our system. However, when a dataset is augmented, it achieved the better accuracy than the original datasets. The dataset with and without augmentation of a chest X-ray images is trained on a different learning rates and the best accuracy is found by keeping the learning rate of 0.0001. However, as an extended version of this article, we can explore different other deep learning models that can be implemented with and without additions of the dense layer. These are These are the examples where our system has false prediction. The row 1 shows the false positives, however the row 2 shows the false negative examples of a COVID, lung opacity, normal viral pneumonia. These clinical characteristics of a coronavirus disease published in 2000s in China, whereas in the second we have performance of the radiologist in a differentiating COVID-19 from the non-COVID-19 viral pneumonia at chest X-ray images, while the third one is a coronavirus disease pneumonia relationship to the negative RT-PCR testing, while the fourth one is a COVID-19 ARC or not. Thank you very much.
Bismillahirrahmanirrahim. In the name of Allah, the most beneficent, the most merciful. I am Sayyida Zuriyat Zahra Ali, crew member of Community of Research and Development and a student of University of Engineering and Technology, Texla, Department of Electrical Engineering. I am going to present my paper in International Conference on Advances in Mechanical Engineering 2021, and the topic of my presentation or research is a novel intelligent model for COVID-19 detection using cuff oscillations and Hjorth descriptors. The co-authors are Engineer Misha Aruj Khan, Engineer Kawal Habib, Sania Harim Khan, and Faizan Tariq. The table of contents include motivation, introduction, diagnosis, literature review, materials and methods, results, discussions, conclusions, References. Motivation. It was detected in the Chinese city of Wuhan and was reported to the World Health Organization on December 31, 2019. It has affected more than 50 million people and killed 14 million globally, and claimed over the lives of 2.53 million and affected over 114 million globally as of April 2021. People with a compromised immune system or elderly people mostly are more likely to develop serious illness, including heart, kidney failures, particularly kidneys or septic shocks, etc. Introduction. What is a coronavirus? Coronavirus or COVID-19 is an infectious disease caused by SARS-CoV-2 virus, or that is severe acute respiratory syndrome, or ARDS, acute respiratory distress syndrome, a family of viruses that affect respiratory tract or causes diseases from common cold to pneumonia. It usually lives in bats as it's transmitted from bats to humans and can transmit between humans via respiratory droplets. Most people who fall sick with COVID-19 will experience mild to moderate symptoms and recover without special treatment. However, some will become seriously ill and require medical attention. This virus can spread from an infected person's mouth or nose in small particles when they cough, speak, sneeze, sing, or breathe. Within 2 to 14 days of this contact, the newly infected person develops symptoms. And dry cough, weakness, fever are physical symptoms in mild to medium cases, while shortness of breath, tiredness, fever are signs of some extreme cases. People who have asthma are more susceptible to the virus and can become seriously ill as a result. Coronavirus was detected in the Chinese city of Wuhan and reported to the World Health Organization on December 31, 2019. And as we can see that in this figure, in December 31, China alerted WHO to several pneumonia cases. From January 7, France confirmed Europe's first coronavirus case. On January 11, China announced first death from coronavirus. At January 13, WHO report cases in Thailand. January 30, China alerts WHO to several pneumonia cases. February 2, first death outside China reported in Philippines. To February 7, Chinese doctor and whistleblower, he died. Until February 14, Egypt confirmed Africa's first case of coronavirus. Symptoms of coronavirus. The symptoms of coronavirus include shortness of breath, high fever, vomiting, pneumonia, coughing, diarrhea, etc. Currently, coronavirus is diagnosed using time-consuming and inaccessible RT-PCR, that is reverse transcription polymer chain reaction testing. But due to the lack of medical equipment, medical personnel, and healthcare facilities, such kit is not readily accessible. Novel coronavirus can be identified using machine learning techniques as well. Additionally, it can forecast the virus's nature around the world, but machine learning also requires a large amount of data to classify or predict this disease. Recently, artificial intelligence has been implemented in the healthcare sector widely. There are so many applications in the field of speech and audio. AI has created a space. It is used for the screening and early detection of different diseases, which could help in saving a large number of lives. Literature review. A computer system was developed by authors in one to detect COVID in two stages. For calculation, high-level data frames, mean and standard deviation were computed, and the results, and by using SVM classifier, the results show that the system achieved 92.7% sensitivity, 88.58% specificity, and 90.69% region under the curve. The authors in C3 used another method for pneumonia, childhood pneumonia diagnosis using a cough. By using a logistic regression classifier, the sensitivity and specificity of 94 and 88% was achieved. In the authors of six presented CNN and transfer learning based automated detection for datasets of normal pneumonia and COVID-19 X-ray images. The results of this study demonstrate that by using deep learning, the accuracy, sensitivity, and specificity of 96.78, 98, and 96.46% was achieved. Convolutional neural network is a fast and efficient detection tool for COVID-19. So this method was used in Bhaval Victoria Hospital. By using chest radiographs, they found that the average accuracy, specificity, and sensitivity of 96, 95, and 96.24% was achieved. The proposed methodology of the detection of COVID-19 subjects is shown in this figure. The methodology works in basically 4 steps. The first step involves data collection, cuff auscultation recording, data repository, storing the signals or audio files in the data repository. The stethoscope fitted with a microphone recorded the cuff auscultations. Then, in the second step, the signal pre-processing and segmentation is done by the removal of, first of all, the DC component was removed by doing amplitude normalization and then using empirical mode decomposition for pre-processing. The third step involves feature extraction. For feature extraction, Hjorth descriptors were used, whose parameters include activity, mobility, and complexity. And in the end, classification was done using medium K nearest neighbor to classify dry cough, wet cough, and COVID cough. For data collection, we have designed low-cost and efficient auscultation sensor to gather the sound signals for the detection of viruses. The system includes a stethoscope, a sensitive microphone, an amplifier circuit, and a sound card. By placing auscultation sensor near the left or right lung, the microphone starts sensing cough auscultations. Cough auscultations are basically the cough sounds heard within the lungs to diagnose COVID-19. 3 kinds of cough signals were collected, that is wet, dry, and COVID cough. A wet cough, also known as productive cough, is a cough that produces mucus, whereas a dry cough doesn't produce mucus. During the compilation of cough auscultations, each participant produced 25 seconds long signal. Later, we divided the signal into 5 seconds so pre-processing and segmentation could be done easily. The frequency range of cough auscultations was 1 to 2 kHz and the sampling frequency of experimental signal was set to 8 kHz by using Nyquist sampling theorem. Dataset. The dataset was collected from local hospitals and it includes 29 females for COVID cough collection, 62 for wet cough, 57 for dry cough, and 49 males for COVID cough, 51 for wet cough, and 65 for dry cough. In total, the overall collected dataset consists of 1579 cough auscultations. The following figure shows the raw signal for cough auscultations, that is COVID cough, dry cough, and wet cough. And it can be seen from this figure that the 3 coughs are different from each other. The next step after collecting the cough auscultations is pre-processing. In pre-processing, the first step is DC removal, DC offset removal. DC offset is a mean amplitude displacement from zero. If the resulting waveform appears above or below the zero line, there is probably a DC offset. DC offset is a potential source of clicks, distortion, and loss of audio volume. The second step in pre-processing is normalization, that is amplitude normalization. It is essential for algorithms to model data accurately. It maintains the ratios and general distributions in data and keeps the values across all the columns within a certain limit. We can also apply normalization to single or multiple columns in the same data set. So the pre-processing, the following figure shows the pre-processing signals after the normalization and DC offset removal is done. Signal segmentation. The next step is signal segmentation. Signal segmentation is done to segment out the region of interest from a time domain signal. Cuff auscultations have strong amplitudes in power spectrum where frequencies are less than 2 kHz. So here we have segmented this region from a pre-processed cuff auscultation signal whose frequency range is 8 kHz with the help of empirical mode decomposition. Now, what is empirical mode decomposition? Empirical mode decomposition, or EMD, is an adaptive time-space analysis method suitable for processing series that are non-stationary and non-linear. Empirical mode decomposition performs operations that partitions a series into intrinsic mode functions without leaving the time domain. These modes provide insight into various signals contained within the data. The EMD algorithm is based on the premise that every non-stationary and non-linear signal is made up of a variety of signal intrinsic oscillation modes. EMD decomposes a pre-processed cuff auscultation into its constituent intrinsic mode functions as shown in the figure, which are locally orthogonal, and a leftover signal known as residual signal. The D part shows that the segmented cuff auscultation signals for dry cough, wet cough, and COVID cough. Feature extraction. For feature extraction, Hjorth descriptors are used here. Also, they are also called as normalized shape detectors, which consist of parameters that are used to define the complexity of biomedical signals. Hjorth descriptors or Hjorth parameters are indicators of statistical properties used in signal processing in time domain. These parameters are activity, mobility, and complexity. These descriptors are widely used in previous studies as a measuring tool for human health using EEG, electroencephalography, time domain signals, lungs, sounds, etc. Activity shows that the magnitude variations in the signal, its small value signifies a small peak intensity difference. Signal mobility is the first derivative that shows the variance of signal gradient, while frequency variations are shown by complexity. The following figure shows the activity versus complexity and mobility versus complexity. The next step is classification. Classification in machine learning is a supervised learning approach in which the computer program learns from the data given to it and make new observations or classifications. Two classifiers are used here called as weighted k-nearest neighbors and decision tree. The weighted k-nearest neighbor algorithm is based on the supervised learning approach. KNN assumes new and existing cases which are identical and assigns new case to the category nearest to the existing labels. The decision tree algorithm can be used to solve regression and classification problems. It learns basic decision rule from training data and creates model using this data for prediction of variables, class, or significance. In this study, weighted K-NN classifier took 472.22 seconds to train the Hjorth descriptors with a prediction rate of 29,000 observations per second. The total misclassification cost of the prediction value is 3, as shown in the figure. The weighted K-NN used 10 nearest neighbors per prediction value. This classifier scored 99.8% sensitivity, 97.82% specificity, 99.8% accuracy, and precision of 99%. The false value for COVID cough is 0.8%, while true value for COVID cough is 99.2%, and for wet and dry cough are 100%, as shown in figure. Fine decision tree classifier took 10.145 seconds to train the Hjorth descriptors with a prediction rate of 10,000 observations per second. The total misclassification cost of the prediction value is 80. Fine decision tree classifier uses 100 splits while splits criteria was Gini's diversity index. This classifier scored 93.93 sensitivity, 92.02% specificity, 94% accuracy, and 93.03% precision rate. And TPR and FNR denotes true positive rate and false negative rate. From the results, it was found that The weighted KNN achieved 99.8% accuracy, and fine decision tree classifier achieved an accuracy of 94.4% and 93.03% precision. Performance evaluation of Hjorth descriptors. The results show that a dry cough has the largest activity and mobility, while COVID-19 cough has the highest complexity. The activity parameter of dry cough shows uniformity in time domain, while COVID cough mobility value shows that the most spread and variation. Due to the amplitude normalization phase of pre-processing, all reported parameter values are very small. Hjorth descriptor benefits from reduced cost computing and fast feature extraction as it has three parameters in comparison to other approaches. Thus, the time domain Hjorth descriptor values are much smaller but much more consistent. Conclusion. The COVID-19 virus is a terrifying label all over the globe. Several COVID-19 related experiments have been conducted, particularly the screening process to monitor the disease's transmission. Lung sounds in COVID cough auscultations can be used to test for lung abnormalities in patients. Here we have proposed an intelligent machine learning model for COVID-19 detection using cough auscultations collected from Pakistani hospitals. It is an efficient and accurate diagnosis, effective, and it is cost friendly, no danger to human health, and it will assist people in Asian countries in predicting the existence of COVID-19 in the initial phases. We have used here weighted KNN and fine decision tree classifier, which results in a cumulative accuracy of 99.8 and 99.4%. Here are the references. Thank you.